This session, you may put up my slides if you would. Thanks. This session was started decades ago. It is a tutorial overview and is intended in part for those not familiar intimately with language of medicine or voice science or speech pathology or voice pedagogy, to get some basic vocabulary so that you can enjoy more of the scientific papers that will be presented for the rest of the week. For some of you, the information presented will be basic and review. For that, we apologize only a little. For others, we hope this gives you the grounding that you need to enjoy the meetings. Those of you who are singing teachers and voice pedagogues may find yourselves a little confused with some of the basic science research papers the first year that you are here. If you make this a regular pilgrimage, by the second or third year, you will be explaining things to the people next to you. It always works that way. Instrumentalists know what makes up their instruments. There is nary a violinist who doesn't know the difference between the neck and the strings. Yet, singers, actors, certainly speakers, are very often completely clueless when it comes to the makeup of their instruments. For them, as well as for those of us who care for the voice and study the voice, understanding the basic building blocks is absolutely essential. So we will start today with a basic overview of what makes up the voice and how it works. The human voice is extraordinary. In a moment, it can convey the terror of a scream or the beauty of a song. It is our oldest instrument. It's been studied at least since the time of Hippocrates, and one would think that we knew all about it. Surprisingly, it isn't so. Much of what we know about the anatomy of the voice has been learned since the 1970s, and we learn new information certainly every year, really every month or more often, including basic things about fundamental anatomy. There are still many mysteries for those of you who are interested in making a career of studying the voice. The voice consists of more than the larynx. The anatomy of the voice includes the entire body. If you look at any singer, you can see that. And if you ask any singer, he or she will tell you that. Although it is less obvious to physicians and speech-language pathologists. But if you watch any singer performing, you can see that much is involved. For those of you in the room with gray hair, that's Bruce Springsteen. The larynx receives the greatest attention because it is the part we get to operate on. And it's the part that most people think of as the voice. You'll have to pardon my little bit of throat clearing here. It's terribly advertising. In fact, the larynx is not even essential to voice production. Cancer patients who undergo laryngectomy and have no larynx speak perfectly intelligibly. It is, however, essential for normal or superior voice production. AV people, my little arrow doesn't show on the screen. So if you have a pointer somewhere, that would be lovely. Sure, I didn't bring my green one because I thought I could use my little Control A function. No, I have an arrow here. Okay, what did you just do? Thank you so much. We'll go high tech. That, by the way, is right there at the limit of my computer skills. The larynx can be divided into skeleton, mucosa, intrinsic, and extrinsic muscles, each of which may be responsible for a voice complaint, and each of which we attend to during the course of voice training. The laryngeal skeleton is made up of the thyroid, cricoid, and paired arytenoid cartilages, and other structures that are less important for today. If you can remember the names thyroid, cricoid, and arytenoid, you know nearly all of the anatomy of the larynx. This is not rocket science. The thyroid cartilage is C-shaped, open in the back. The cricoid cartilage beneath it is circumferential, and perched atop the cricoid cartilage are the paired arytenoid cartilages. Above the thyroid cartilage is the hyoid bone, also known as the tongue bone. When we are born, this complex is around the level of C3, the third cervical vertebra. As we age, it descends closer to the level of C6 or C7, and that lengthening of the vocal tract is part of what we hear as vocal maturation or aging. In addition, you will note that immediately behind the laryngeal structures is the spinal column with a little bit of intervening pharyngeal soft tissue. So there's a solid bony wall back there. Hence, if one is struck directly from the front, there is not much give in the back. When we are born, the laryngeal cartilages are cartilage. Starting in our teens and early 20s, they begin to ossify and turn to bone. So when we are young, if the larynx is struck, say, by an elbow or a steering wheel, and is pushed backwards, it's flexible and tends to snap back into position. If that happens to an old person, such as I, the larynx is brittle and fractures. Are there any laryngologists in the room? No physicians? A few physicians. All physicians who know more than I. That fact is also important with some of our laryngeal surgery. For example, if we are working with a transgender patient and want to raise pitch by bringing the cricoid and thyroid closer together or subluxing them and fusing them, that works pretty well on someone in her 30s and not so well at all on someone in her 60s. Here's a larynx, front, back. There's the thyroid prominence, also known as an Adam's apple, more prominent in men, much less developed, if developed, in women or children. And here is the larynx split down the center. So that's anterior or front, back. This white structure labeled vocal cord is mislabeled. First of all, we dropped the term vocal cord about 30 years ago in favor of vocal fold, which is more descriptive. Second, that white structure, which extends from the vocal process of the arytenoid cartilage here to about the midpoint on the inside of the thyroid cartilage here, is not the vocal cord or the vocal fold, but please remember it as a reference point. We shall return to it. Because the thyroid cartilage is C-shaped, there's no part of it in the back, but because the cricoid is circumferential, you see that front and back with arytenoid atop it. The cartilages are connected by joints. The thyroarytenoid joint and the cricothyroid joint. Again, thyroid, cricoid, arytenoid, you have almost all the anatomy. Anatomists have very little imagination. These joints are not screw-like. They move in multiple planes. They are synovial joints made up of the same materials that constitute elbows and knees and subject to the same afflictions. Infection, arthritis, aging changes, subluxation, and dislocation. Much has been written about injury to the cricothyroid joint. That can occur from many things, including intubation trauma during surgery. Much less has been written about injury to the cricothyroid joint, but it is more common than most people recognize and quite important. As we will discuss, the cricoid and thyroid move in relation to each other because of the superior laryngeal nerve to control pitch. If that joint becomes stiff or fused, that motion becomes impossible, and we have the same effect as if there were weakness of the superior laryngeal nerve. This joint is just under the skin. So elbow injuries from basketball and hockey and many other sports. Injuries, one of my favorite, happened to an actor during Oklahoma. The actress next to him made a grand gesture and essentially gave him a karate chop into his larynx. These injuries are not rare, they're just rarely recognized. This is a larynx facing you. Thyroid prominence or Adam's apple, thyroid cartilage, cricoid cartilage, hyoid bone. So what would you guess this membrane is called? That's the cricothyroid membrane. That's the thyrohyoid membrane. Use your X-ray vision and think about where you think the vocal folds are. When you are working with a voice, whether you're a voice teacher or a surgeon or a speech language pathologist, you should be able to picture in your mind's eye the structures upon which you are intervening. As we remove the thyrohyoid membrane, we see the epiglottis attached inside the thyroid cartilage. It flips down when we swallow to keep the Valpolicella out of our airways. Here we see the cricothyroid membrane removed. This area is artificially widened a little bit, and see the signet ring-shaped cricoid cartilage, and atop it, the pyramidal arytenoid cartilages with their vocal processes, muscular processes, and apices. Note that those cartilages are sitting on top of a curved surface. I will show you more, but the motion of the arytenoid cartilages is exceedingly complex and essentially impossible so far for us to recreate once it has been damaged. Anterior, posterior, hyoid bone, epiglottis, thyroid cartilage. These are those white structures that were incorrectly labeled vocal cord. They emanate from the vocal process of the arytenoid cartilage and insert into the thyroid cartilage. For the surgeons in the room, I'm sure you will all recall that there is an embryologic fusion plane here where the vocal process joins the body of the arytenoid. They are of embryologically different origin. It is a fracture line waiting to happen. That is one of the reasons why when we manipulate this area, for example, for an arytenoid dislocation, we never do so by putting an instrument underneath the vocal process and pulling up. that will create an injury called a vocal process avulsion, in which the vocal fold separates from the body of the arytenoid and window shades up, which creates an astonishingly bad voice because all of the tension is removed from the vocal fold. We used to say that arytenoids rock, glide, and rotate. We use different language now, but as a basic understanding, here is an arytenoid, here's the cricoid, here's a nice little joint space. It looks just like a little temporomandibular joint or a little shoulder joint, normally. Here the vocal folds are in adduction, as if you were speaking or singing. And notice they sit on top of this curved cricoid surface. Here you see the same vocal folds abducted, for example, during breathing. And note that they haven't just moved sideways, but their entire attitude has changed and they have slid down a curved surface. Exceedingly complex motion. These are arytenoids. This is the cricoid. Okay. AV people, this worked very nicely. AV, when we put these together and clicked on them before the talk, they moved. See if you can make that happen again. I will be happy to sacrifice my pointer for a little motion while I'm up here suppressing emotion. Thank you. That's one. Now that's, run it again please if you would, or if I can. No, it's all yours. If you would do the same thing again. And run the other one too, please. And look at the very tiny area of actual attachment. This is a CT scan from a living human done by Jean Abitbol and Albert Castro. It is so delicate and the area of contact so small that it's quite astonishing that we don't have cricoarytenoid injury far more often than we do. Would you play the lower one more time, please? See, most of the arytenoid is not even in contact with the thyroid. It's a very small joint area.
Could you use your pointer to point out where it's connecting? Because I don't see it.
If I have my pointer again, I will. If you give me back my pointer and make it move, the only area, where is the pointer? There it is. One more time. Please make it play. Please make it play. The answer is no. See me after the lecture. Right there is the area of attachment.
Oh.
The rest of that is out in the breeze.
Thank you.
You're very welcome. The intrinsic muscles are responsible for adduction, that means bringing together, adding, abduction, pulling apart, and longitudinal tension. They are able to function because they receive signals from the brain, even in tenors, through nerves. And if you can remember one nerve and one muscle, you will do fine on your multiple choice test. The superior laryngeal nerve innervates the cricothyroid muscle, which is the one you use to change pitch. Pretty much everything else is innervated by the recurrent laryngeal nerve. So superior laryngeal nerve, cricothyroid. You also only need to remember one more muscle, the posterior cricoarytenoid muscle, which is the abductor. It opens up the vocal folds and allows you to breathe. Everything else protects your airway and lets you sing Mozart. When I was a resident in Ann Arbor in the 70s and up to 1980, we learned about all of these muscles for one reason only, and that was to pass boards, after which we forgot them because they were worthless. No longer so. We study these muscles daily in our patients with laryngeal electromyography, and our speech-language pathologists and singing voice specialists design muscle-specific voice rehabilitation programs to strengthen weakened muscles and bring the system back into balance. So we will review quickly what these muscles do. The posterior cricoarytenoid, cleverly enough, arises from the posterior aspect of the cricoid, attaches to the muscular process of the arytenoid, and when it fires, muscles shorten when they contract. It pulls the muscular process this way, so the vocal process is swung out this way, and the vocal folds open. You do that every time you sniff, or when you take a breath to speak or sing. This is the neutral position of the edge of the vocal fold. So when the posterior cricoarytenoid muscle fires to open up the vocal fold, it pulls the vocal fold up and out. Each of these muscles does more than just bring the vocal folds together and take them apart. They also affect the shape of the contact edge of the vocal fold. Ordinarily, they do it in concert. The cricothyroid muscle, we've already said, is used to increase longitudinal tension to stretch the vocal fold so you can raise pitch. So as you would expect, the edge sharpens as it fires. Rod Shearer never likes it when I use this example, but if you think of stretching a rubber band, it sharpens and thins. And the same sort of thing happens here. The vocalis muscle runs where that structure mislabeled vocal cord was. When that fires, what do you think happens? What moves? Nothing. It's isometric. It goes between two structures that are stable. So that muscle, the vocalis muscle, when it fires, bulks up. That creates lateral resistance, so that when it's struck by the other vocal fold, it doesn't get blown out of the way. That is why, when there is weakness, paralysis, or paresis of that muscle, for example, from injection of botulinum toxin for a patient with spasmodic dysphonia, a dysphonia that interrupts voice, we restore fluency, but we don't restore normalcy. If you weaken this muscle in a spasmodic dysphonia patient who is a singer, when he or she tries to sing loudly, the voice tends to hurt because we need that lateral resistance. That's the vocalis muscle, the medial belly of the thyroid muscle.
We lost a speaker.
I lost what?
It's quieter all of a sudden.
My audience says we just lost a speaker. Not I presume, but probably one of the electronics. Okay, there's been a request for more volume. Does that help? Thank you. I think we all responded simultaneously. The lateral cricoarytenoid muscle, are we restored? Thank you. The lateral cricoarytenoid muscle brings the vocal folds to the midline, and the interarytenoid muscles close the posterior glottic chink. Ordinarily, they do that in concert, and we have a fairly broad area of contact. All of the laryngologists in the room have at one time or another seen people with mass lesions called granulomas. They're not actually granulomas, but we call them that. On the vocal process, they get operated upon, and then they come back. And then people figure out that people have reflux, and they operate on them again after treating the reflux, and they come back. So not knowing what else to do, they go to speech pathologists, who also fail. If you look at many of those people in frame-by-frame analysis or with high speed, you will see what's called a lateral cricoarytenoid dominant closure pattern, in which the LCA muscle predominates and there is a point of forceful striking at the vocal process, and then the interarytenoid coordinates and closes the glottal gap, and it's that forceful trauma that causes the problem. So that's very hard to fix with speech pathology alone, but very easy to fix with a little botulinum toxin into the lateral cricoarytenoid muscle. And when that gets weakened, then speech pathologists can retrain people so that when the Botox wears off, the patterns have changed. For the laryngeal electromyographers in the room, it's very easy to tell when you're in the LCA. Ordinarily, we inject the vocalis muscle, the thyroarytenoid muscle. When you have somebody say E or phonate, in that muscle you hear a constant output. The LCA brings the vocal fold to the midline and then doesn't have much to do. So you hear a big impulse and then it quiets down. So you know exactly where your injection needles are. The interarytenoid closes the posterior glottic chink, which may not necessarily be a good thing to do. This is an area that has, as far as I'm concerned, not been studied as well as we need to. Many people have a little gap in the backs of the vocal folds, both women and men, although it seems to be somewhat more common in women. If you want to teach people how to close that gap, you can put a scope down through their nose and tell people with visual feedback to close the gap, and most people can learn to do it. However, it may well be there for a reason. It may be part of the pressure control system. I don't think we know definitively. Ron, Chuck, do you agree that we don't know definitively? Probably from a scientist is about the best you ever get. So in any case, the fact that a posterior glottic chink exists does not necessarily mean that it is causing any kind of a problem. The cricothyroid muscle, which is innervated by the one nerve I asked you to remember, which is called? Right, the superior laryngeal nerve. I agree. There will be a quiz. Brings the cricoid and thyroid closer together. In so doing, it rocks the cricoarytenoid joint back a little further away from its attachment. It stretches the vocal fold, increases longitudinal tension, and therefore pitch in ways that we shall discuss. The extrinsic laryngeal muscles attached to the outside of the larynx. There are people who consider the cricothyroid muscle extrinsic, most of us included with the intrinsic muscles. These muscles, the extrinsic or strap muscles, the muscles that stand out on your average, mediocre Helen tenor, are responsible for vertical laryngeal position. In classical Western singing, the larynx tends to drop a little bit and remain stable during singing. These muscles control that. So if they are injured, for example, if these muscles are cut during thyroidectomy, that's the thyroid gland right there, just below the larynx, and then they heal and shorten and the larynx tilts a little bit, that is potentially problematic. Inside the larynx, we have true vocal folds, false vocal folds, and a little pocket in between called the ventricle of Morgani. This is cut anterior, posterior. This is cut from front to back. So you are looking at the airway, the trachea, the true vocal folds with the vocalis muscles, the ventricle, and the false vocal folds. Note several things. First, The vocal fold edges are fairly expansive. This is a three-dimensional structure. It's not like two pieces of paper. It's more like two fingers touching each other. There's considerable vertical height to the contact area. Second, note this steeple-shaped convergence, which is important to the aerodynamics of the system. Those of you who were forced to take physics for some reason will probably remember that when you have a flow system and it goes through an area of resistance, it forms little whorls called vortices. And the flow system is influenced in large measure by downstream resistance. The supraglottic larynx is part of that downstream resistance system. There is much that we do not know about the false vocal folds, but they are probably more important than we understand fully. So as enlightened surgeons, we don't do things that we used to do when we were trained decades ago, like cut them off so we can see the vocal folds better. They do serve a function even if we don't understand the function entirely. But certainly some of their function has to do with airflow, and much of the presence of a person's voice has to do with the aerial ratio differences between the laryngeal inlet and the pharynx. It's a complex and incompletely understood system. The vocal folds have a musculomembranous portion and a cartilaginous portion. When we're born, it's about 50-50. In adulthood, it's about 3/5 musculomembranous and 2/5 cartilaginous. We older physicians were trained that the musculomembranous portion is phonatory and responsible for making vocal sounds, and the cartilaginous portion is respiratory. This is a similar picture of a real person: vocal folds, false vocal folds, arytenoids, epiglottis. We know that under pathologic circumstances, at least, that is not entirely true. For example, in a patient with a web that obliterates the musculomembranous vocal folds, vocal pitch may be high, but some of those patients have remarkably clear, almost normal voices. When we look at them with stroboscopy, the cartilaginous mucosa can produce a mucosal wave that looks for all the world like a normal mucosal wave. So, under pathologic circumstances, this area of the vocal fold can function well as an oscillator. It seems plausible that under high performance voice circumstances, it also may have an effect. Until we know better, as surgeons, it is prudent to treat the entire vocal fold surface with respect. It used to be that we considered this respiratory and of no importance, so when we had lesions in the back of the larynx, we'd just take a laser and burn them off and not worry about it. I don't personally believe that we know enough to do that. And until we know a whole lot more, all of the vocal fold should be treated as if it has an effect on phonation. And we need to know more. The covering of the vocal fold is lubricated. The wetness allows the vocal folds to come together and pull apart efficiently. The lubrication is supplied by glands which include mucinous and serous glands. Mucinous glands put out thick stuff, serous glands thin, watery stuff. The balance between the two determines the viscosity of our lubrication and its effectiveness. If it becomes too thick, just as if the oil in your car engine is too thick, the efficiency of the contact and release and vibration of the system is affected adversely. Many of the things that we think of as dehydrating or drying the voice, like antihistamines, don't necessarily dehydrate, but rather shift from serous to mucinous predominance, thicken our lubrication, and thereby interfere with voice. One of the things we do when we hyperhydrate is shift toward a somewhat thinner lubricating system. That's one of the reasons for hydration. So when you're thinking about those sorts of problems, you need to think not just about how wet, but how viscous. It has to do with surface tension and other things. Most of the respiratory system is covered in pseudostratified ciliated columnar epithelium with little hairs on it to move things around the mucus blanket. Those little cilia are pretty delicate. If you put them on the edge of the vocal fold and smash them together 200 times a second, they wouldn't last long. So the engineer was smart enough not to do that. The area of the vocal folds themselves doesn't have cilia. It's the only area of stratified squamous epithelium within the airway, specialized for vocal fold contact. The covering of the airway is much more complicated than we used to think. In 1975, Minoru Hirano described the structure of the edge of the vocal fold, published in English in 1977. And this slide is the keystone of modern voice thought and voice surgery. This is a vocal fold. The other one would be over here. The space in between is the glottis. I like to fantasize that this was the one time that an anatomist had a sense of humor. The glottis is a space. Everything in this system is referred to as glottic, level of the vocal folds, supraglottic above, subglottic below. There is no glottis. It is a non-existent structure. When the vocal folds are making contact, it isn't there, and it is the reference point for the system. I'm sure it isn't so, but I like to think that some anatomist got a chuckle out of that somewhere in history. So, this is not mucosa like the lining on the inside of your mouth. It has an epithelium, superficial, intermediate, and deep layers of lamina propria and your old friend, the vocalis muscle. The epithelium and superficial layer, also Reinke space, form the mucosal wave and glide over the surface. The thyroarytenoid muscle, medial belly, as you already know, forms lateral resistance, so it allows enough strength in this system to allow the vocal folds to entrain the airstream without being pushed out of the way and fluttering. The vocal ligament in between the intermediate and deep layer of lamina propria constitutes the vocal ligament as a transition layer. This structure is what was mislabeled vocal cord. Around it is built what we know of as the vocal fold. So we understand the anatomy in layers. We understand the physiology or function in layers. The epithelium and superficial layer make the mucosal wave. The body creates the lateral resistance. We also understand healing in layers. There are very few fibroblasts that make scar in the epithelium or superficial layer, but the vocal ligament and muscle are rich in scar-forming potential. And we understand pathology in layers. Nodules, cysts, polyps, many other benign disorders are disorders of the epithelium or superficial portion of the superficial lamina propria. So understanding that, we were able to develop treatment in layers, develop precise surgical instrumentation and surgical procedures that are restricted to the area that is deranged without traumatizing subjacent layers and provoking scar formation that obliterates this elegant structure. And that, in a nutshell, is the difference between voice surgery and care today and voice surgery and care in the 1970s. The books we write about that are a couple thousand pages long, but that's the essence of it, right there. So how many of you lie awake at night wondering how the epithelium is attached to the superficial layer of the lamina? Well, the answer is that there is a basement membrane. And that basement membrane has type 7 collagen fiber loops that go back up and reinsert into the basement membrane, through which pass type 3 collagen fibers that link and keep the epithelium from flying off, unless, of course, you have a disease such as epidermolysis bullosa et dystrophica, in which case the epithelium does fly off, just like skin can fly off. The number of these linkages and the chemical and protein structures in this region vary from person to person. I believe that this is more important than many of us have appreciated. This is individualized, this structure, and healing potential is individualized. Why is that important? Well, think about this. We have patients who come in with vocal nodules, children, and they come in with a mother, and the kid screams, and the mother screams, and the aunt screams, and we say, no wonder you have vocal nodules. Everybody screams, and you put the whole family in therapy. One of the great things about Philadelphia is that we have more than 500,000 Italians living in South Philadelphia. And if you go stand in the middle of the street in the summer in South Philly at 6 o'clock, you can hear the dinner conversations for 6 blocks in any direction. How come only one kid gets nodules? It's not that simple. It's not just behavioral. There is much more to this system than we have understood so far. So for those of you who are young, this is a very fruitful field. We know less than we know. There is much left to learn. The vocal folds are an oscillator. They make a noise. That noise passes through our upper respiratory system, which acts as a resonator. In order to create a noise in the first place, we need some power to set the oscillator in vibration. So how does that all work? And I will keep this short because the rest of the speakers will go through all of this again with you in great detail. Our newest area is neurolaryngology. And Dr. Larson will give you some introduction to neurolaryngology, but I assure you that we could spend the entire symposium week talking about neurolaryngology. But just think about this much. You want to sing a note, or you want to speak, perhaps, ask a question. You coordinate information on both sides of your brain. You preset the entire anatomic system below the vocal folds, chest, abdomen, thorax, neck, vocal folds, everything else, drawing upon your auditory memory. You then open your mouth and utter, usually pretty close to target, but within milliseconds, you listen to that sound and adjust it to target. And if you are a singer and trained, and you're in a noisy environment like a choir or a band, you make the same adjustments by feel using tactile feedback rather than by ear, and can adjust to target. An enormously complex and exceedingly quick system. Again, a great surprise that it does not go awry more often than it does. How many singers in the room? All right, in general, singers and singing teachers know more about doctors than doctors about respiration and voice. Sad, but still true. There are exceptions, of course, those who specialize in laryngology. For 500 years, singers have recognized that voice and breath are intertwined critically. Basics of respiration. We use a combination of active and passive forces. I am up here pontificating, so I take a breath and use muscles of expiration in order to phonate. You, those of you who are still awake, are taking a breath and relaxing. and using the passive recoil of your thorax and muscles to let out a portion of your air without any expiratory effort. In order to breathe in, you use your diaphragm primarily and your external intercostal muscles. Those are muscles between your ribs. When you flex your diaphragm muscles, your diaphragm drops. It expands the area of your thorax and you suck in air to create a vacuum. Singers talk about the diaphragm as a support muscle that isn't quite accurate. The primary muscles of expiration raise the pressure in the chest either by tightening the contents, the muscles around the gut and forcing the gut contents up, or pulling the sternum down, but in either case, they're making the space in which your air is contained smaller. So think about a balloon, not a perfect analogy, but if you have a balloon and you want to get air out of it in some kind of controlled fashion, first of all, do you want a full balloon or a partially empty balloon? You want a full balloon. If it's partially empty, you're all over the place. If it's full, you almost have to barely think about moving your hands together, and you create the force. How do you create the force? Physics again. You have a fixed amount of gas in the container, you make the container smaller, the pressure in the gas goes up. You're able to force it out under control. Oversimplistically, that's what you learn to do with this system and direct the force going up. Now, I said that I equivocated a little bit on the diaphragm. Diaphragm is primarily an inspiratory muscle. There was some lovely work by Phonatory and Lee Henderson, and I think Sundberg, in Stockholm that showed that the diaphragm is co-activated in elite singers. That is, when you have a soprano singing high notes, she uses the diaphragm a little bit during expiratory activities, partly probably as a pressure control system. So none of this is quite as straightforward as we teach you. Let's look at a basic phonatory cycle. These are the vocal folds arbitrarily together. You hold them together with a voluntary amount of adductory force. You decide how tightly you hold your vocal folds together. You then create pressure below the vocal folds. When that subglottal pressure overcomes the adductory force, you blow the vocal folds apart. That allows air to flow, which creates a Bernoulli effect. That's what sucks your shower curtain in or pulls you toward a rapidly passing truck. And the elasticity of the tissues, together with the Bernoulli force, makes the vocal folds close. Note that the vocal folds open from the bottom up and from the back forward, and also close from the bottom up. Remember I told you there's a large contact surface like fingers, and it works differentially. This is called a vertical phase difference. If something interferes with it, like a mass or swelling or scar, we lose vocal efficiency and we have symptoms. When we need to restore scar surgically, we need to do it over a vertical plane to reconstruct this ability. Note also that we're talking about the vocal folds opening and closing, not vibrating like strings. And they can do this pretty fast, 1,200 to 1,400 times a second. We have no muscle refractory systems anywhere close to that fast. So this is not just a muscle system, it's a myoelastic aerodynamic system. It's the airflow and the tissues working together. We create a sound at the vocal folds. It's a fairly boring sound. If you amputate people just above their vocal folds, we try to do that only with selected administrators and plaintiffs and attorneys. But if you do that, you get a sound much like a trumpet with mouthpiece without the trumpet attached. Boring signal, whether you're Pavarotti or mortal, that's what you get. It drops off at about 12 decibels per octave. We then run it through our system of infinitely variable interconnected resonators, and when it comes out, instead of being boring, it looks like a nice Pocono mountain range. The peaks in this range are called formants, and those formants are responsible for several things, including vowel intelligibility and what we call ring, whether it's in speech or in song. It's the ability to be heard over noise. If you have the singer's formant or speaker's formant, you can sing and be heard over choir and orchestra. You can go to a wedding or to an Eagles Dallas game and yell all you wish and not be hoarse and be heard. If you don't, you do other things to compensate. Interestingly, the singer's formant occurs in slightly different frequencies for different voices, but it's more or less in the 3,000 hertz range. Where is 3,000 hertz? If you take Papadotti's voice and notch filter a couple hundred hertz around 3,000, his voice will disappear into the crowd and you won't hear him over the orchestra. That's 3.5 octaves above middle C, 2.5 octaves above the highest note he could sing. So it's counterintuitive that it should make a difference, but it makes all the difference, and it's one of the things that we try to develop during voice therapy, and of course during the singing training. So how do we control all of this stuff, and why do we care? Fundamental frequency. Well, you already know, right? You recruit your superior laryngeal nerve, fire your cricothyroid muscles, bring your cricoid and thyroid cartilages closer together, stretch your vocal folds, so what? So you have a larger area over which your subglottal pressure acts, so it opens the vocal folds more efficiently. And the vocal folds are stretched a bit, so they close more efficiently, so they do it more times in a second. So your frequency goes up and your pitch goes up. Is that the only way to control pitch? No, and you know that. If you turn your water faucet on slowly and then increase the water flow, what do you hear? As you increase flow, you also increase frequency. And people who have no cricothyroid function still have a fifth to an octave. So there's a practical value to it. But we don't do that routinely because it interferes, among other things, with the way we control intensity. How do you control intensity? Suppose you hear a wonderful afternoon of lectures and want to applaud vigorously. Do you do this? No. You spread your hands apart and slap them together, and you do something quite similar with your vocal folds. You increase your adductory force, you increase your subglottal pressure. When you blow the vocal folds apart, you blow them far apart, you increase the amplitude of displacement from the midline. You get rapid airflow. Because you've blown them far apart, they snap together and suddenly interrupt that airflow. And that, through a mechanism slightly more complicated than I just gave you, is how you get yourself louder. Who cares? Well, we care. All of the things I've talked with you about and many others we measure every day in our patients in the clinical voice lab. As one quick example, flow glottography, inverse filtering, gives us information about the relationship between adductory forces and subglottal pressure. On the one extreme, we have the breathy voice, obviously inefficient. On the other extreme, we have the pressed voice of the baritone announcing to the world that he is indeed a baritone. That kind of voice is also the voice that leads people to develop vocal nodules and other problems. And we have flow phonation, which I hope I've been using, which is an appropriate balance, an efficient balance between adductory forces and subglottal pressure. People get into trouble trying to be heard. That's where my patients come from. They don't use the system effectively. One of the places where you can be heard is at the glottal source. So going from pressed phonation to flow phonation can give you a 15 decibel advantage at the glottal source. That's work from Dr. Sundram. Is that much? If you have a paper machine that's 90 decibels, and you turn on a second paper machine that's 90 decibels, what do you have? It's not 180, these are logarithms. You have 93, but it's loud. You can hear the difference. If you turn on two more, you now have 4, you're screaming for ear protectors. What are you up to? 96. How many of those machines do you have to turn on to get a 15 decibel advantage? 32. So we are not talking about small things when we are talking about voice therapy and singing lessons, optimizing the function of the system. We can measure acoustic output in various ways. We can measure vibration, either directly visually with strobe and high speed. We can measure muscle function through laryngeal electromyography. And essentially, we now have the ability to do what we couldn't do 30 years ago, which is, in addition to using our ears and our art, which are still critical, we can do an objective systems analysis to learn whether the support system, the phonatory delicate muscles, and the resonators are doing what they are supposed to be doing. And if not, what is malfunctioning? And then we can, in a planned and systematic fashion, analyze the system, know what's wrong, establish goals, and with a combination of medicines, therapy, and occasionally surgery, restore the system to proper function and balance. And I will tell you, it's great fun to be able to practice that way. And the principles are the same, whether you are a laryngologist, a speech-language pathologist, or a voice teacher. I thank you for your attention, and I am delighted to turn the program over